topic of neoplasia, and today we'll talk about fundamental hallmarks of cancer. There are 8 changes in cell physiology which are considered the hallmarks of cancer, and they include self-sufficiency in growth signals, insensitivity to growth inhibitory signals, altered cellular metabolism, evasion of apoptosis, limitless replicative potential, sustained angiogenesis, invasion and metastasis, and evasion of immune surveillance. So let's start with hallmark 1, self-sufficiency in growth signals. Normal cells require growth signals before they start dividing by moving from a quiescent state into an active proliferative state. These signals are transmitted into the cell by transmembrane receptors that bind distinctive classes of signaling molecules. Tumor cells generate their own growth signals, thereby reducing their dependence on stimulation from their normal tissue microenvironment. This liberation from dependence on external signals disrupts a critically important homeostatic mechanism that normally operates to ensure a proper behavior of various cell types within a tissue. 3 common strategies for achieving growth signal autonomy include alteration of extracellular growth signals. Many cancer cells acquire the ability to synthesize growth factors to which they are responsive, creating a positive feedback signaling loop. The second common strategy for achieving growth signal autonomy is alteration of transcellular transducers of those signals. And the third one is alteration of intracellular circuits that translate those signals into action. So in case of alteration of transcellular transducers of those signals, receptor overexpression may enable the cancer cells to become hyper-responsive to ambient levels of growth factors that normally would not trigger proliferation. Alterations in components of the downstream cytoplasmic circuitry that receives and processes the signals emitted by growth factors receptors can release a flux of signals into cells without ongoing stimulation by their normal upstream regulators. Tumor cells may also acquire the ability to recruit their normal neighbors by inducing them to release abundant fluxes of growth stimulating signals. The cell cycle has key checkpoints shown on the picture. 3 key checkpoints are the cell growth, G1 checkpoint, the G2 checkpoint, the mitosis checkpoint. The DNA synthesis checkpoint is another checkpoint. The cell growth G1 checkpoint allows the cells to proceed into the S phase of the cell cycle and continue on to divide or delay division or enter resting stage. The cell spends most of the cycle in the G1 phase. G1 is where the cell carries out its main functions. If the cell has performed its functions and has grown to significant size to be divided in half, key proteins will signal the cell to proceed to the S phase and stimulate DNA replication to begin. If the cells are not to divide, such as some muscle and nerve cells, the cell will stop at this checkpoint and move into a resting phase. Some cells may stay in this resting period permanently, never dividing. The second checkpoint is located at the end of G2 phase. Passing this checkpoint triggers the start of mitosis. If this checkpoint is passed, the cell initiates the many molecular processes that signal the beginning of mitosis. The mitosis checkpoint determines the end of one cycle and the beginning of the next. This checkpoint occurs at the point in metaphase where all the chromosomes should have aligned at the metaphase plate. This checkpoint signals the beginning of anaphase, allowing the cell to complete mitosis and prepare for the beginning of G1 of the next cell cycle. The DNA synthesis checkpoint determines if the cell is ready for mitosis. DNA repair enzymes check the replicated DNA at this point. If the checkpoint is passed, the many molecular mechanisms and processes needed for mitosis will begin. Within a normal tissue, anti-growth signals maintain cells in a non-dividing state, ensuring cellular quiescence and tissue homeostasis. Signals in this case include soluble growth inhibitors, immobilized inhibitors embedded in extracellular matrix on surfaces of nearby cells. These growth inhibitory signals are received by transmembrane cell surface receptors coupled to intracellular signaling circuits. Normal cells respond to anti-growth via components governing the transit of the cell through the G1 phase of its growth cycle. Cells monitor the external environment during this period and, on the basis of sense signals, decide whether to proliferate, to be quiescent, or to enter into the post-mitotic state. Cancer cells must evade negative regulation of cell proliferation. Apoptosis programmed cell death is a self-destruct mechanism triggered in normal cells in response to whether external death inducing signals or signals of intracellular origin. When initiated, the apoptosis effectors initiate a cascade of proteolysis caspases by which the cell is progressively disassembled and then consumed both by its neighbors and by professional phagocytic cells. The p53 tumor suppressor gene is probably the most notable internal abnormality sensor that plays a key role in tumor development. p53's protein induced apoptosis in response to DNA damage, thus preventing the cell from accumulating additional mutations that might lead to uncontrolled growth. Most normal cells have a finite replicative potential. Multiple lines of evidence links length of DNA telomeres, chromosome ends composed of multiple tandem hexanucleotide repeats and shorten progressively with each replicator, and the link of DNA telomeres is often linked with the replicative potential of the cell. The immortalization of cells that proceed to form tumors has been attributed to their ability to maintain telomeric DNA at lengths sufficient to avoid triggering senescence or apoptosis, achieved most commonly by upregulating expression of telomerase. Recently, additional proliferation-related functions for telomerase were discovered, but their involvement in cancer is still undetermined. Angiogenesis is the formation of new blood vessels from pre-existing vessels. Like normal tissues, tumors require nutrients and oxygen as well as an ability to evacuate metabolic wastes and carbon dioxide, obligating virtually all cells in a tissue to reside in a capillary blood vessel. In the adult, as part of physiologic processes such as wound healing, angiogenesis is turned on but only transiently. In contrast, during tumor progression, an angiogenic switch is almost always activated and remains on, causing normally quiescent vasculature to continually sprout new vessels that help sustain expanding neoplastic growths. Tumor angiogenesis offers an uniquely attractive therapeutic target. Indeed, one that is shared in common by most and perhaps all types of human tumors. The next decade will probably produce a catalog of the angiogenic regulatory molecules expressed by different types of tumors. Will a single anti-angiogenic therapeutic will suffice to treat all tumor types, or whether an ensemble of such therapeutics will need to be developed, each responding to a distinct program of an angiogenesis that has been developed by a specific class of human tumors? This remains a question. At a certain point during the development of most types of human cancer, primary tumor masses spawn pioneer cells that move out, invade adjacent tissues, and travel to distant sites where they may succeed in founding new colonies. These distant settlements of tumor cells, metastases, are the cause of 90% of human cancer deaths. The capability for invasion and metastasis enable cancer cells to colonize new terrain in the body where nutrients and space are not limiting. The multi-step process of invasion and metastasis has been schematized as a sequence of discrete steps, often termed the invasion-metastasis cascade. This depiction envisions a succession of cell biologic changes, beginning with local invasion, then intravasation by cancer cells into nearby blood and lymphatic vessels, transit of cancer cells through the lymphatic and hematogenous systems, followed by escape of cancer cells from the lumina of such vessels into the parenchyma of distant tissues, the formation of small nodules of cancer cells, and finally the growth of micrometastatic lesions into macroscopic tumors, this last step being termed colonization. Interestingly, some tumors have been found to contain two subpopulations of cancer cells that differ in their energy-generating pathway. One subpopulation consists of glucose-dependent cells that secrete lactate, whereas cells of the second subpopulation preferentially import and utilize the lactate as their main energy source. Altered energy metabolism is proving to be a widespread in cancer cells, as many of the other cancer-associated traits that have been accepted as hallmarks of cancer and therefore may be considered as a new hallmark. On the other hand, it is not necessarily functionally independent from the other core hallmarks, as many of the involved proteins are common. In recent years, an increasing body of evidence suggests that the immune system operates as a significant barrier to tumor formation and progression. Solid tumors therefore find a way to evade immune destruction. Possible mechanism: highly immunogenic cancer cell clones are routinely eliminated in immunocompetent hosts, a process that has been referred to as immunoediting, leaving behind only weakly immunogenic variants to grow and generate solid tumors. Immunoevasion is therefore another emerging hallmark whose generality as a core hallmark capability remains to be firmly established. Carcinogenic agents inflict genetic damage, which lies at the heart of carcinogenesis. The three classes of carcinogenic agents have been identified: chemicals, radiant energy, and microbial products. Chemicals and radiant energy are documented causes of cancer in humans, and oncogenic viruses are involved in the pathogenesis of tumors in several animal models and some human tumors. We will discuss each class of agents and it will be considered separately. Of note, however, several may act in concert or sequentially to produce the multiple genetic abnormalities characteristic of neoplastic cells. We'll start with chemical carcinogens. More than 200 years ago, the London surgeon Sir Percival Pott, shown on the picture on the left, correctly attributed scrotal skin cancer in chimney sweeps to chronic exposure to soot. On the basis of this observation, the Danish Chimney Sweeps Guild ruled that its members must bath daily. No public health measure since that time has achieved so much in the control of the form of cancer. Subsequently, hundreds of chemicals have been shown to be carcinogenic in animals. Some of the major agents are presented on the table on the slide. Because malignant transformation results from mutations, it should come as no surprise that most chemical carcinogens are mutagenic. Indeed, all direct and ultimate carcinogens contain highly reactive electrophile groups that form chemical adducts with DNA, as well as with proteins and RNA. Any gene may be the target of chemical carcinogens, but understandably it is the mutation of important cancer genes, such as ARIAS and TP53, that is responsible for carcinogenesis. Indeed, specific chemical carcinogens such as aflatoxin B1 produce characteristic mutations in TP53, such that detection of mutations with particular codons strongly points toward aflatoxin as the causative agent. Such specific mutational signatures also exist for cancers caused by ultraviolet light, tobacco smoke, and other environmental carcinogens, and are proven to be useful tools in epidemiologic studies of carcinogenesis. Carcinogenicity of some chemicals is augmented by subsequent administration of promoters, which are by themselves non-tumorigenic. To be effective, repeated or sustained exposure to the promoter must follow the application of mutagenic chemical or initiator. The initiation-promotion sequence of chemical carcinogenesis raises an important question. Since promoters are not mutagenic, how do they contribute to tumorigenesis? Although the effects of tumor promoters are pleiotropic, induction of cell proliferation is a sine qua non of tumor promotion. It seems most likely that while the application of an initiator may cause the mutational activation of an oncogene such as ARIAS, subsequent application of promoters leads to clonal expansion of initiated cells. Forced to proliferate, the initiated clone of cells accumulate additional mutations, developing eventually into malignant tumor. Indeed, the concept that sustained cell proliferation increases the risk for mutagenesis and hence promotes neoplastic transformation also is applicable to human carcinogenesis. We discussed briefly the chemical carcinogenesis. Let's talk about the radiation one. Radiation, whatever its source, is an established carcinogen. Unprotected miners of radioactive elements have a 10-fold increased incidence of lung cancers. A follow-up study of survivors of the atomic bombs dropped on Hiroshima and Nagasaki disclosed a markedly increased incidence of leukemia after an average latent period of about 7 years, as well as increased mortality rates for thyroid, breast, colon, and lung carcinomas. The nuclear power accident at Chernobyl in the former Soviet Union continues to exact its toll in the form of high cancer incidence in the surrounding areas. More recently, it is feared that radiation released from a nuclear power plant in Japan damaged by a massive earthquake and tsunami will result in significantly increased cancer incidence in the surrounding geographic areas. Therapeutic irradiation of the head and neck can give rise to papillary thyroid cancers years later. The oncogenic properties of ionizing radiation are related to its mutagenic effects. It causes chromosome breakage, chromosomal rearrangement such as translocations and inversions, and less frequently point mutations. Biologically double-stranded DNA breaks seem to be the most important form of DNA damage caused by radiation. The oncogenic effect of ultraviolet rays merits special mention because it highlights the importance of DNA repair in carcinogenesis. Natural UV radiation derived from the sun can cause skin cancers. At greatest risk are fair-skinned people who live in locales such as Australia and New Zealand that receive a great deal of sunlight. Non-melanoma skin cancers are associated with total cumulative exposure to UV radiation, whereas melanomas are associated with intense intermittent exposure, as occurs with sunbathing. UV light has several biologic effects on cells. Of particular relevance to carcinogenesis is the ability to damage DNA by forming pyrimidine dimers. This type of DNA damage is repaired by the nucleotide excision repair pathway. With extensive exposure to ultraviolet light, the repair systems may be overwhelmed and skin cancer results. As mentioned earlier, patients with inherited disease xeroderma pigmentosum have a defect in the nucleotide excision repair pathway. As expected, there is a greatly increased predisposition to skin cancers in this case. Many DNA and RNA viruses have proved to be oncogenic in animals and disparate as frogs and primates. Despite intense scrutiny, however, only a few viruses have been linked with human cancer. Scores of genetically distinct types of human papillomavirus have been identified. Some types, like 1, 2, 4, and 7, cause benign squamous papillomas in humans. Genital warts have low malignant potential and are also associated with low-risk human papillomavirus, predominantly human papillomavirus 6 and human papillomavirus 11. By contrast, high-risk human papillomavirus, like types 16 and 18, cause several cancers, particularly squamous cell carcinoma of the cervix and anogenital region. In addition, at least 20 of oropharyngeal cancers, particularly those arising in the tonsils, are associated with high-risk human papillomavirus. The oncogenic potential of human papillomavirus can be related to products of two early viral genes, E6 and E7, each of which have several activities that are pro-oncogenic. The E6 protein binds to and mediates the degradation of p53 and also stimulates the expression of telomerase reverse transcriptase, the catalytic subunit of telomerase, which you will recall contributes to the immortalization of cells. E6 from high-risk human papillomavirus types has a higher affinity for p53 than E6 from low-risk human papillomavirus types, a property that is likely to contribute to oncogenesis. The E7 protein has effects that complement those of E6, all of which are centered on speeding cells through the G1S cell cycle checkpoint. It binds to the RB protein and displaces the E2F transcription factors that are normally sequestered by RB, promoting progression through the cell cycle. As with E6 proteins and p53, E7 proteins from high-risk human papillomavirus types have a higher affinity for RB than do E7 proteins from low-risk HPV types. E7 also inactivates the cycle-independent kinase inhibitors P21 and P27 and binds and presumably activates cyclins E and A. To summarize, high-risk human papillomavirus encode oncogenic proteins that activate PP and P53, activate cyclin CDK complexes and combat cellular senescence. Therefore, it is evident that human papillomavirus proteins promote many of the hallmarks of cancer. The primacy of human papillomavirus infection in the causation of cervical cancer is confirmed by ineffectiveness of human papilloma vaccines in preventing it. However, infection with human papillomavirus itself is not sufficient for carcinogenesis, and full-blown transformation requires the acquisition of mutations in host cancer genes such as RAS. A high proportion of women infected with human papillomavirus clear the infection by immunologic mechanisms, but others do not, some because of acquired immune abnormalities such as those that result from HIV infection. As might be expected, women who are co-infected with high-risk human papillomavirus types and HIV are at particularly high risk for developing cervical cancer. Helicobacter pylori infection is implicated in the genesis of both gastric adenocarcinomas and gastric lymphomas. First incriminated as a cause of peptic ulcers, Helicobacter pylori now has acquired the dubious distinction of being the first bacterium classified as a carcinogen. The scenario for the development of gastric adenocarcinoma involves increased epithelial cell proliferation on a background of chronic inflammation. The inflammatory milieu contains numerous genotoxic agents, such as reactive oxygen species. The sequence of histopathologic changes consists of initial development of chronic inflammation followed by gastric atrophy, intestinal metaplasia of the lining cells, dysplasia and cancer. This sequence takes decades to complete and occurs in only 3% of infected patients. The Helicobacter pylori genome also contains genes directly implicated in oncogenesis. Strains associated with gastric adenocarcinoma may have been shown to contain a pathogenicity island that contains cytotoxin-associated aging. Although Helicobacter pylori is non-invasive, cytotoxin-associated aging is injected into gastric epithelial cells where it has a variety of effects, including the initiation of a signaling cascade that mimics unregulated growth factor stimulation. The importance of neoplasms ultimately lies in the effects on patients. Although malignant tumors are, of course, more threatening than benign tumors, morbidity and mortality may be associated with any tumor, even a benign one. Indeed, both malignant and benign tumors may cause problems because of location and impingement on adjacent structures, functional activities such as hormone synthesis or the development of paraneoplastic syndromes, bleeding and infection when the tumor ulcerates through adjacent surfaces, symptoms that result from rupture, infarction, and cachexia or wasting. We will further discuss the effects of a tumor on the host, grading clinical staging of cancer, and the laboratory diagnosis of neoplasms. Location is crucial in both benign and malignant tumors. A small pituitary adenoma can compress and destroy the surrounding normal gland, giving rise to hypopituitarism. A 0.5 centimeter leiomyoma in the wall of the renal artery may encroach on the blood supply, leading to renal ischemia and hypertension. A comparably small carcinoma within the common bile duct may induce fatal biliary tract obstruction. A tumor may ulcerate through a surface with consequent bleeding or secondary infection. Benign or malignant neoplasm that protrude into the gut lumen may become caught in the peristaltic pole of the gut, causing in-tissue intussusception and intestinal obstruction or infarction. Many cancer patients suffer progressive loss of body fat and lean body mass, accompanied by profound weakness, anorexia, and anemia, a condition referred to as cachexia. There is some correlation between the size and extent of spread of cancer and the severity of the cachexia. However, cachexia is not caused by the nutritional demands of the tumor. Although patients with cancer often are anorexic, current evidence indicates that cachexia results from the action of soluble factors such as cytokines produced by the tumor and the host rather than reduced food intake. In patients with cancer, calorie expenditure remains high and basal metabolic rate is increased despite reduced food intake. This is in contrast with the lower metabolic rate that occurs as an adaptive response in starvation. The basis of these metabolic abnormalities are not fully understood. It is suspected that tumor necrosis factor and other cytokines produced by macrophages in response to tumor cells or by the tumor cells themselves mediate cachexia. Human necrosis factor suppresses appetite and inhibits the action of lipoprotein lipase, preventing the release of free fatty acids from lipoproteins. There is no satisfactory treatment for cancer cachexia other than removal of the underlying cause of the tumor. Symptom complexes that occur in patients with cancer and that cannot be readily explained by local or distant spread of the tumor or by the elaboration of hormones indigenous to the tissue of origin of the tumor are referred to as paraneoplastic syndromes. They appear in 10 to 15% of patients with cancer, and their clinical recognition is important for several reasons. Such syndromes may represent the earliest manifestation of an occult neoplasm. In affected patients, the pathologic changes may be associated with significant clinical illness and may even be lethal. The symptom complex may mimic metastatic disease, thereby confounding treatment. The paraneoplastic syndromes are diverse and associated with many different tumors. The most common paraneoplastic syndromes are hypercalcemia, Cushing syndrome, and non-bacterial thrombotic endocarditis, and the neoplasms most often associated with these and other syndromes are lung and breast cancers and hematologic malignancies. Hypercalcemia in cancer patients is multifactorial, but the most important mechanism is the synthesis of the parathyroid hormone-related protein by tumor cells. Also implicated are other tumor-derived factors such as tumor growth factor alpha and the active form of vitamin D. Another possible mechanism for hypercalcemia is widespread osteolytic metastatic disease of bone. Of note, however, hypercalcemia resulting from skeletal metastasis is not a paraneoplastic syndrome. Cushing syndrome arising as a paraneoplastic phenomenon usually is related to ectopic production of adrenocorticotropin hormone or adrenocorticotropin hormone-like polypeptides by cancer cells, as occurs in the small cell carcinoma of the lung. Paraneoplastic syndromes also may manifest as hypercoagulability, leading to venous thrombosis and non-bacterial thrombotic endocarditis. Other manifestations are clubbing of the fingers and hypertrophic osteopathy in patients with lung carcinomas. Grading of a cancer is based on the degree of differentiation of the tumor cell, and in some cancers the number of mitosis and the presence of certain architectural features. Grading schemes have evolved for each type of malignancy, generally range from 2 categories to 4 categories. Criteria for the individual grades vary in different types of tumors, and so are not detailed in this lecture, but all attempt in essence to judge the extent to which the tumor cells resemble or fail to resemble their normal counterparts. Although histologic grading is useful, the correlation between histologic appearance and biologic behavior is less than perfect. In recognition of this problem and to avoid spurious quantification, it is common practice to characterize a particular neoplasm in descriptive terms. For example, well-differentiated mucin-secreting adenocarcinoma of the stomach, as shown on the left picture, or poorly differentiated pancreatic adenocarcinoma on the right picture. The staging of solid cancers is based on the size of the primary lesion, its extent of spread to regional lymph nodes, and the presence or absence of blood-borne metastasis. The major staging system currently in use around the world is the American Joint Committee on Cancer Staging. This system uses a classification called the TNM. T for primary tumor, N for regional lymph node involvement, and M for metastasis. TNM staging varies for specific forms of cancer, but there are general principles. The primary lesion is characterized as T1 to T4 based on increasing rate. T0 is used to indicate an in situ lesion. N0 would mean no nodal involvement, whereas N1, 2, and 3 would denote involvement of an increasing number and range of nodes. M0 signifies no distant metastasis, whereas M1 or sometimes M2 reflects the presence and estimated number of metastases. To summarize, cachexia, defined as progressive loss of body fat and lean body mass accompanied by profound weakness, anorexia, and anemia, is caused by release of cytokines by the tumor or the host. Paraneoplastic syndrome, defined as systemic symptoms that cannot be explained by tumor spread or by hormones appropriate to the tissue, are caused by the ectopic production and secretion of bioactive substances. Grading of tumors is determined by cytologic appearance and is based on the idea that behavior and differentiation are related, with poorly differentiated tumors having more aggressive behavior. Staging, determined by surgical exploration or imaging, is based on size, local and regional lymph node spread, and distant metastasis. Staging is of greater clinical value than grading. Every year, the approach to laboratory diagnosis of cancer becomes more complex, more sophisticated, and more specialized. Frozen section diagnosis, shown on the picture, is a method in which a sample is quick frozen and sectioned, permits histologic evaluation within minutes. In experienced, competent hands, frozen section diagnosis is accurate, but there are particular instances in which the superior histologic detail provided by more time-consuming routine methods is needed. In such instances, it's better to wait a few days despite the drawbacks than to perform inadequate or unnecessary surgery. Fine needle aspiration of tumors is another approach that is widely used. It involves aspiration of cells from a mass followed by cytologic examination of cells after they have been spread out on the slide. This procedure is used most commonly with readily palpable lesions affecting the breast, thyroid gland, lymph nodes, and salivary glands. Modern imaging techniques permit extension of the methods to deeper structures, such as the liver, pancreas, and pelvic lymph nodes. Use of this diagnostic modality obviates surgery and its attendant risks. Although it entails some difficulties, such as small sample size and sampling errors, in experienced hands it can be reliable, rapid, and useful. Cytologic Papanicolaou smears provide another method for the detection of cancer. Historically, this approach has been used widely for discovery of carcinoma of cervix, often at an in situ stage, but now it is used to investigate many other forms of suspected malignancies such as endometrial carcinoma, bronchogenic carcinoma, blood and prostate tumors, and gastric carcinomas. For the identification of tumor cells in the abdominal pleural joint and cerebrospinal fluids, and less commonly for evaluation of other forms of neoplasia. Neoplastic cells are less cohesive than other and are therefore shed into fluids or secretions. On the left picture, normal Papanicolaou smear from the uterine cervix, large flat cells with small nuclei are typical. On the right picture is abnormal smear containing a sheet of malignant cells with large hyperchromatic nuclei. Nuclear pleomorphism is evident, and one cell is in mitosis. The shed cells are evaluated for features of anaplasia indicative of the origin from a tumor. The gratifying control of cervical cancer is the best testament to the value of the cytologic method. Immunohistochemistry offers a powerful adjunct to routine histologic examination. Detection of cytokeratin by stains performed with specific monoclonal antibodies points to a diagnosis of undifferentiated carcinoma rather than large cell lymphoma. Similarly, detection of prostate-specific antigen in metastatic deposits by immunohistochemical staining allows definitive diagnosis of a primary tumor in the prostate gland. Immunocytochemical detection of estrogen receptors allows prognostication and directs therapeutic intervention in breast cancers. Flow cytometry is used routinely in the classification of leukemias and lymphomas. In this method, fluorescently labeled antibodies against cell surface molecules and differentiation antigens are used to obtain the phenotype of malignant cells. Biochemical assays for tumor-associated enzymes, hormones, and other tumor markers in the blood cannot be utilized for definitive diagnosis of cancer. However, they are used with varying success as screening tests and have utility in monitoring the response to therapy or detecting disease recurrence. PSA, used to screen for prostatic adenocarcinoma, is one of the most frequently used tumor markers in clinical practice. Prostatic carcinoma can be suspected when elevated levels of PSA are found in the blood. However, PSA screening also highlights problems encountered with use of virtually every tumor marker. Although PSA levels often are elevated in cancer, PSA levels also may be elevated in benign prostatic hyperplasia. Furthermore, there is no PSA levels that ensures that a patient does not have prostate cancer. Therefore, the PSA test suffers from both low sensitivity and low specificity, and its use as a screening tool have become quite controversial. The PSA assay is extremely valuable, however, for detecting residual disease or recurrence following treatment for prostate cancer. An increasing number of molecular techniques are being used for the diagnosis of tumors and for predicting their behavior. Because each T cell and B cell has unique antigen receptor gene rearrangements, polymerase chain reaction PCR-based detection of rearranged T cell receptor or immunoglobulin genes allows monoclonal and polyclonal proliferations to be distinguished. Many hematopoietic neoplasms, as well as a few solid tumors, are defined by particular translocations, so the diagnosis can be made by detection of such translocations. For example, fluorescence in situ hybridization, FISH, or PSR analysis can be used to detect translocation characteristic of Ewing sarcoma and several leukemias and lymphomas. PCR-based detection of BCR-ABL transcripts can confirm the diagnosis of chronic myeloid leukemia. Finally, certain hematologic malignancies are now defined by the presence of point mutation, in particular oncogenes. For example, the diagnosis of another myeloid neoplasm called polycythemia vera requires the identification of specific mutations in JAK2, a gene that encodes a non-receptor tyrosine kinase. Certain genetic alterations are associated with a poor prognosis, and therefore the presence of these alterations determines the patient's subsequent therapy. Fluorescence in situ hybridization and PCR methods can be used to detect amplification of oncogenes such as HER2 and NMYC, which provide therapeutic and prognostic information for breast cancers and neuroblastomas, respectively. Sequencing of cancer genomes is now routine in some centers, allowing for the identification of point mutations in cancer genes such as TP53 that predict a poor outcome in many different types of cancer. Although not yet standard of care, efforts are ongoing to develop tests that assess the host immune response to tumors, for example, by quantifying the number of infiltrating cytotoxic T cells, as this is too helpful in gauging prognosis. Another emerging use of molecular technology is for the detection of minimal residual disease after treatment. For example, detection of BCR-ABL transcripts by PCR assays gives a measure of residual disease in patients treated for chronic myeloid leukemia. Recognition that virtually all advanced tumors are associated with both intact circulating tumor cells and products derived from tumors has led to interest in following tumor burden through sensitive blood tests designed to identify tumor-specific nucleic acid sequences. Germline mutations of several tumor suppressor genes, such as BRCA1, increases a patient's risk for developing certain types of cancer. On the left picture is a schematic representation of BRCA and BRCA2 functions and on the right you see loss of second BRCA allele in the BRCA mutation carrier. Therefore, detection of these mutated alleles may allow the patient and the physician to devise an aggressive screening protocol as well as an opportunity for prophylactic surgery. In addition, such detection allows genetic counseling of relatives who are at risk. Therapies that directly target specific mutations are increasingly being developed, and therefore detection of such mutations in tumor can guide the development of targeted therapy. It is now becoming evident that certain targetable mutations transgress morphologic categories. One example involves valine for glutamate substitutions in amino acid 600 V600E of the serine threonine kinase Prov, which you will recall lies downstream of RAS in the growth factor signaling pathway. Melanomas with this V600E Prov mutation respond well to Prov inhibitors, whereas melanomas without this mutation saw no response. Subsequently, it was realized that the same V600E mutation is also present in a subset of many other diverse cancers, including carcinomas of the colon and thyroid gland, most hairy cell leukemias, and many cases of Langerhans cell histiocytosis, shown on the picture. These tumors are morphologically diverse and have distinct cells of origin, but they share identical oncogenic lesions in a common pro-growth pathway. Until recently, molecular studies of tumors involved the analysis of individual genes. However, the past few years have seen the introduction of revolutionary technologies that can rapidly sequence an entire genome, assess epigenetic modifications genome-wide, quantify all of the RNAs expressed in a cell population, measure many proteins simultaneously, and take a snapshot of all of the cell's metabolites. Therefore, the diagnosis, management, and study of cancer has entered the age of omics. The most common method for large-scale analysis of RNA expression is in use in research laboratories has been based on DNA microarrays, but newer methods involving RNA sequencing that offer a more comprehensive and quantitative assessment of RNA expression are beginning to supplant older methods. However, RNA is prone to degradation and is more difficult to annihilate to work with than DNA in clinical practice. Furthermore, DNA sequencing is technically simpler than RNA sequencing, permitting the development of methods that rely on massively parallel sequencing, so-called next-generation sequencing, that can be readily performed on virtually any tissue specimen. On the picture, you see an outline of Illumina genome analyzer sequencing process. Adapters are nailed to the ends of sequence fragments. Fragments bind to prime-loaded flow cell, and bridge PCR reactions amplify each bound fragments to produce clusters of fragments. And during each sequencing cycle, one fluorophore-attached nucleotide is added to the growing strands. Laser excites the fluorophores in all the fragments that are being sequenced, and an optic scanner collects the signals from each fragment cluster. Then the sequencing terminator is removed and the next sequencing cycle starts. While whole genome sequencing to manage patients can be performed, most efforts in the clinical realm are focused on developing sequencing methods that permit identification of therapeutically actionable genetic lesions in a timely fashion at a reasonable cost. Such approaches seem particularly applicable to tumors such as lung carcinomas that are genetically diverse and require a personalized approach if targeted therapies to succeed. Therefore, the current trend in molecular diagnostic laboratories to develop methods that permit several hundred exons of key genes to be sequenced simultaneously at sufficient depths to reliably detect any mutations that might be present in as few as 5% of tumor cells. A second method that is moving into clinical practice involves the use of DNA arrays to identify changes in DNA copy numbers such as amplifications and deletions. Arrays containing probes that span the entire genome at some standard spacing can detect all but the smallest copy number aberrations, providing information that is complementary to that obtained from focused DNA sequencing. The excitement created by the development of new techniques for the global molecular analysis of tumors has led some scientists to predict that the end of histopathology is in sight. However, histopathologic inspection of tumors provides information about important characteristics of cancers, such as neoplasia, invasiveness, the tumor heterogeneity, that cannot be gleaned from DNA sequences. Histopathology coupled with in situ biomarker tests performed on tissue sections also remains the best way to assess tumor. Stromal cell interactions such as angiogenesis and host immune responses, the latter may have an increasingly important role in guiding therapeutic interventions that are designed to counteract immune evasion by tumors. Therefore, what lies ahead is not the replacement of one set of techniques by another. On the contrary, for the foreseeable future, the most accurate diagnosis and assessment of prognosis in cancer patients will be arrived at by a combination of morphologic and molecular techniques. Several sampling approaches exist for the diagnosis of tumors, including excision, biopsy, fine needle aspiration, and cytologic smears. Immunohistochemistry and flow cytometry studies help in the diagnosis and classification of tumors because distinct protein expression patterns define different entities. Proteins released by tumors into the serum, such as PCA, can be used to screen populations for cancer and to monitor for recurrence after treatment. Molecular analyses are used to determine diagnosis and prognosis, to detect minimal residual disease, and to diagnose patients with a hereditary predisposition to cancer. Molecular profiling of tumors by RNA expression profiling, DNA sequencing, and DNA copy number arrays are useful in molecular stratification of otherwise identical tumors or those of distinct histogenesis that share mutation for the purpose of targeted treatment and prognostication. Assays of circulating tumor cells and of DNA shed into blood, stool, sputum, and urine are under development. Thank you for your attention.